Hi, everyone. Welcome. This is Joe Gallo-Vaspi, and I'd like to just go through a couple of quick administrative points so that we can keep this operation flowing. First off, make sure that your microphone is turned off, and please keep it off through the entirety of the session. I suggest and recommend that you also turn your camcorders off once the presentation begins, so that during that time your image doesn't become a distraction to the presenter or to the other participants. Any questions that you may have or comments, you can put them in the chat, and then the moderators will consolidate them as we go along. If you would please, we'd appreciate if you could change your name to include the country that you represent. You can do that by just going to your particular image, click on the three dots, and it'll allow you to modify your name. And of course, everything you need to be aware of is that this is going to be recorded and made available later. And of course, the typical disclaimer, okay, this session is for informational, educational purposes only. Anything that's expressed in the presentation is not intended as a recommendation or any sort of medical advice or treatment advice. We strongly suggest that you consult with your doctor for any specific items that you wish to pursue. And with that, I will be happy to turn this over to our fearless leader, Mark Lichty.
Joe, thank you, and welcome to all of you. It really feels good to be back amongst our brotherhood of the prostate. And we appreciate your feedback, your continued support. You've suggested in your feedback that we focus on your questions, and we want to do that. So we're going to be looking for your questions in the chat box. And we got some feedback too that the webinars were too long. If you feel they're too long, don't hesitate to leave. We're not going to be offended. Just go when you have to go. What we want to do with ASPI is to help men navigate active surveillance. But two, we want to help men feel more at peace when they're on active surveillance. These are anxious times. We have pandemic anxiety and climate anxiety, and even Zoom anxiety for me. And even today, Zoom anxiety, because in one of our webinars, Zoom decided to cut off our registration at 100 when we had 150 registered, and some people weren't happy. And so, we had over 200 registered for that. So that intensified my Zoom anxiety. And today I had internet password anxiety. So anxiety surrounds us. So this is just a wonderful topic. And with regard to cancer anxiety, we've all felt cancer anxiety. For me, it was really intense 17 years ago, as I was the only person I knew who was going on active surveillance. In fact, it wasn't even called active surveillance then, it was called watchful waiting then. And the key for us is to take that anxious energy and transform it into something else that serves you. And it can be controlled just by breathing mindfully. And if we can remember that moment to moment, that will help us all. Some of you may have attended our webinar entitled Active Surveillance, a Peaceful, Easy Feeling. And this webinar is kind of an extension of that. We do believe that you can achieve a sense of peace on active surveillance. We call it peaceful vigilance. And a lot of men will leave active surveillance, not because of medical necessity, but just due to anxiety. And our hope that our presenter today, Lara Bellardita, will help you get control of that anxiety. And I'd like to thank those of you who have donated to us. We don't have staff. It's just men like you that have been on active surveillance. And so we're an unusual organization. We're a patient-led organization, an international patient-led organization, and we make a special effort to reach out to people like Laura, who is a Ph.D. from Italy, and many of our programs have incorporated folks from foreign countries, and we're learning so much from scanning the globe and inviting people from other nations to share with us. I might have said to you in a prior webinar that I don't have any detectable cancer anymore. My last micro ultrasound couldn't detect anything. And so I was thinking that it might be interesting to consider a program where we find men who were diagnosed with prostate cancer and no longer have prostate cancer. And so I'm going to put my email in the chat box. And if anybody out there is like that and thinks that would be a good webinar to have, please send me an email. And so I'd like to introduce Jeff McClellan. He's our fundraising chair, and he's going to make a little pitch, and then he'll introduce Howard Walensky.
Thank you.
Jeff, you're on.
Thank you very much, Mark. I'm speaking here from Northern California. Regardless of politicians and fires, we still exist here. Just a reminder to everyone on today's program that without your support, none of this would happen. None of these programs would happen. As your fundraising chair, ASPA provides education, support, and excellent programming, all done by volunteers. Your donations support our administrative costs that supports everything we do and bring peace and confidence and hope to men with prostate cancer. We appreciate donors. We really, really do. And I want to thank each and every one of you this morning. You have a special place in our hearts. Please visit our website at aspatients.org and hit the donate button and see the many ways you can help us help you. Thank you very much. Now I have the honor to present a distinguished gentleman, Howard Walensky from Chicago. Regardless of the wind, he still prevails. Howard is an outstanding writer, editorialist, and newspaper man. He's written prolifically over the years and shows outstanding scientific research abilities. He is certainly our sage, and without further ado, Howard Walensky, how do you do?
Howard, you're on mute, Howard. Unmute yourself.
I dutifully listened to Joe. Thanks for the kind words, Jeff. Last year, ASPE and the ANCAN organizations ran a survey. We had 165 respondents, and one of the topics was anxiety, what we like to call anxious surveillance. Actually, we don't like to call it, we just call it. And what we found was about 15% of the respondents were generally anxious to begin with. And going on to active surveillance, which is kind of a counterintuitive move for a lot of people to not treat a cancer, may, perpetuated their anxiety. And another 15%, so about 30% of the respondents complained about anxiety connected with their prostate cancer. And when does it happen? Well, it happens when it's about time to have a PSA, or it's time to have an exam, or to have an MRI, or to have a biopsy. And those are the times. And sometimes it builds up over time, and people leave the protocol of active surveillance because the anxiety is too much for them. And some people, like our speaker tonight, for some of you this morning, for the rest of us, has been a leader in researching this topic. And this is Dr. Lara Bellardita. Sorry about that. Getting tongue twisted. For the past decade, she's been a pioneer in researching the psychological issues faced by men on active surveillance. She's been working at the National Cancer Institute in Milan, and along with other private and nonprofit organizations. Quality of life, coping with cancer, patient empowerment, and engaging in the decision-making process are her specialties. And she may as well give her academic credentials. She got her master's in the United States at San Diego State University as a Fulbright Fellow. She received her doctorate from the Catholic University in Milan. And I think it's time for the show. So Lara, why don't you take over?
Good morning and good evening, depending on where you are. Thank you so much for inviting me to have this conversation with you today. I'm very happy to have the chance to share some of my experience, the knowledge that I acquired in this particular field, and I hope I will be able to give some hints that will be useful for you to understand better your emotions when we talk about active surveillance, and let's say manage your emotions so that you can live being in active surveillance as best as possible. I'm going to share my screen because I have some slides that I prepared for today. Let me just show it full screen. Okay. I hope you can see the slides. I just like to give feedback from.
They're showing up fine.
Okay, good. So the topic is anxiety. The main topic is anxiety, but of course we're gonna see how anxiety, the construct of anxiety interacts with other aspects of psychological distress and psychological well-being. I'm gonna give a quick overview of what anxiety is, what do we talk about when we talk about anxiety, and then I'm going to provide some information that is specifically related to anxiety in and active surveillance. I'm going to spend a few words about the management, the multidisciplinary management of active surveillance and how it can actually improve emotional adaptation to the monitoring protocols. And I'll end with something that might sound a bit counterintuitive, that is the idea of considering active surveillance as an opportunity window, as a time and space for learning something about yourself, your own health, and your own psychological well-being. So what are we talking about when we talk about anxiety? The underlying emotion is fear. And fear is something useful, is something that it's good to have. It's something that is wired in our body, in our brain. Is an emotion, is defined as an emotion characterized by feelings of tension. Many of us have experienced in their life how being anxious, feeling fearful immediately brings us to feel more tense, to be more tense in the whole body. So feelings are one of the components, some of the components of anxiety. And then there's a cognitive aspects, so thoughts that are related to what we fear, what we worry about, and sometimes those thoughts can become intrusive. So they basically become the only thoughts that we deal with throughout the day, and sometimes during nights as well. Anxiety is an emotion that is also characterized by physical changes, and most typically an increase in blood pressure, faster breathing, more rapid heartbeat, and as I said before, muscular tension. It has to do with anticipating a potential danger or catastrophe or misfortune. And this anticipation may lead the people to try to avoid the situations that trigger fear and anxiety. So fear is the base, is what represents the fundamental of anxiety, but anxiety and fear are not exactly the same thing. Anxiety is future-oriented. I am anxious about something that I anticipate, and it's a more long-acting response. On the other hand, fear is short-lived, is a short-lived response. Emotions after less than a second, they tend to disappear, and the body goes back to a state of balance. And first of all, and most of all, is an appropriate reaction. As I said before, it's good to have fear because fear protects from danger. So it's one of the factors that contributed to our survival as a species. And usually fear is related to something that we can clearly identify, while anxiety is much more general. So the main message here is it's good to experience fear. It's good to experience anxiety up to a certain level. Anxiety stops to be useful and functional when it lasts longer than necessary. This is a graphic representation of the whole spectrum of fear that you can see on the website of Atlas of Emotions. The Atlas of Emotions website was created by Paul Ekman, who's considered one of the most important researchers in the field of emotions. Is now an emeritus professor, I think, at Stanford. And so if you're interested in reading more, learning more about emotions, and particularly fear, you can definitely refer to the the writings of Paul Ekman, and also of his daughter. I can't recall her name, but You'll find a lot of scientifically based materials on fear and other emotions. So fear can manifest itself in a number of different ways, and anxiety is only one of the possible manifestations of fear. Nervousness belongs to the fear spectrum as well as panic and terror. So experiencing anxiety during active surveillance is normal and should be considered such. It should be monitored though, because if it becomes, if it increases, if the level of anxiety increases towards the level of panic and terror, then at some point it's useful and important to worry about it, to worry about fear. So it's a what are the signs and symptoms that you might want to pay attention to? Feeling restless, wound up or on the edge, being easily fatigued. And fatigue is something that is hard to put in the right box, because it can be related to fear. It can also be related to depressive states. And depression is a completely different thing from anxiety. That is something else that I'd like to emphasize and underline. It's very important to become able to label, to understand emotions and to label them in an appropriate way, because oftentimes people tend to talk about any form of distress as anxiety. So, well, that might not necessarily be the case. So it's important to learn to distinguish your own emotions, to understand them, and to give a name, to give a label to what you're experiencing. Other signs and symptoms of anxiety have to do with difficulty in concentrating or mind going black, a sort of fog state, being irritable, having muscular tensions a lot of time. Chronic pain has to do with anxiety, because having muscle tension all the time may determine pain in the long run. Anxiety has to do with having a difficult time in controlling feelings of worry. So what happens is that people spend most of their time worrying and thinking about potential threats. Symptoms of anxiety are sleep problems, such as difficulty in falling or staying asleep, again, restlessness or unsatisfying sleep, which means being able to sleep but waking up tired nonetheless. These are the things that you might want to kind of monitor. Just like a lot of times I tell to patients that are particularly anxious that it's appropriate to monitor signs and symptoms of anxiety in the long run, exactly as they are monitoring their PSA. So it's good to understand that anxiety is not a good reason. This is a question that I often have been addressing since I started doing research on active surveillance. Anxiety is not a good reason for dropping out from the protocol or even avoiding entering a monitoring protocol at all. Anxiety, if is particularly relevant and significant, needs to be monitored and dealt with. Anxiety disorders that are particularly related to active surveillance are health-related medical anxiety, which is anxiety specifically linked to a medical condition, and it includes the symptoms of intense anxiety or panic that are directly caused by physical health problem. And then another anxiety disorder that is important to talk about when we talk about patients on active surveillance is generalized anxiety disorders, which includes persistent and excessive anxiety and worry about different activities or events, even ordinary routine issues, having a hard time, feeling anxious and worried about going grocery shopping or going to the movies or going anywhere, going to work. The worry is usually out of proportion and is difficult to control. It's very important to take into account a generalized anxiety disorder because oftentimes the patients on active surveillance that develop active surveillance related anxiety are the ones who already have GAS, generalized anxiety disorder. What can you do if you're anxious? I don't like the idea that the word managing anxiety. I don't like the idea of eliminating anxiety. Well, first of all, it's not possible because we cannot decide if we're going to feel fearful or not fearful. It's important to become aware of how you feel. And ask yourself those questions. What am I afraid of? What are my emotions trying to tell me? How can I manage my emotions when they are no longer useful? Remember, I said before that it's good to have fear and anxiety up to a certain extent because they are an alert of a potential threat. And so disease progression may be a potential threat. So I need to have a certain amount of fear, which is what triggers me, motivates me to go and take those exams that are necessary to monitor the journey of the disease. You can deal with anxiety by working on your level of arousal. So doing different activities that lower the activation of the sympathetic nervous system and trigger the action of parasympathetic nervous system. And how do you do that? Well, exercise is extremely important in overcoming exceeding anxiety. And healthy diet is important. It has been shown that what we eat influences our emotions. Learning relaxation techniques can be extremely useful, and it can be a number of techniques: meditation, mindfulness, progressive relaxation, or even doing like very simple exercises like what is usually referred to as the box. You inhale 3 or 4, you count 3, 4 and inhale. You hold the same count. You let go the same count. You hold the same count, and then you start again. So these are like simple exercises that are very, very effective in lowering the physiological arousal and contribute to decreasing the feeling, the activation that is related to anxiety. And then, of course, if you are realizing that anxiety is overwhelming, you should ask for help. See a therapist, search psychological counseling, talk to your doctor. I know it's very difficult to talk to doctors about aspects that are not immediately related to the medical aspects, to the biological aspects of the disease. And even more so during these difficult times, because it has become more challenging to be in touch with physicians, at least in some places, in some countries. Nonetheless, you should keep in mind that it's important for your own health that we're body, we're mind, we're relationships, and more the biopsychosocial model is something that is being socialized in medical profession, and hopefully this trend will increase even more. So when we talk about anxiety, well-being, and coping in active surveillance, usually these are the three main questions that I am asked. How many men are really anxious before diagnosis? How is psychological and subjective well-being affected by living with untreated prostate cancer? And what factors are predictive or associated with psychological subjective well-being for patient on active surveillance? Well, the first one is a very tough question to address, because oftentimes during research on psychological impact of active surveillance, we missed something very important, that was baseline information. We didn't know if patients were anxious before receiving the diagnosis. So that's a very challenging aspect of research on this topic, and it's very hard, which makes it very hard to have a sound answer to that question. We definitely know more about how living with untreated prostate cancer impacts psychological well-being. Since 2007, we have had researchers trying to address this question. I personally started doing research on this topic in 2009, and literature before that is kind of controversial, because in the sample, patients on both active surveillance and watchful waiting were taken into considerations, but the watchful waiting, we know now, is suggested to patients with very different clinical characteristics than active surveillance, than the ones that are taken into account for patients who are proposed active surveillance. So what have we learned in the early studies? We learned that active surveillance living with an untreated prostate cancer has little or no adverse impact on well-being. At the beginning, we looked at the changes over the first 3 and 6 months, and then we looked at changes over the first year, and mostly we tried to see how the progress was in anxiety before and around the first biopsy, because that was a very significant point in the path of active surveillance for patients. We understood that psychosocial well-being of men on active surveillance can be compared to the well-being of patients who were treated and compared to the general population. And here I'm talking about psychosocial well-being, because of course, if we compare men on active surveillance with patients who were treated with prostatectomy or radiotherapy, in terms of functional outcomes, of course, we know that the situation is much better for men on active surveillance. And for functional outcomes, I'm talking about I'm talking about urinary functions and erectile function. We understood, we saw, data showed us that pre-existing personality traits were associated with psychological well-being, and particularly what is referred to as neuroticism and emotional instability was related, as resulted to be related to having a negatively impacted well-being when on active surveillance. And finally, at some point, we had the results of the PROTECT study, because at the beginning, literature did not show results of men directly compared. The PROTECT study randomized patients to either radical prostatectomy or radiotherapy or active surveillance. And results showed that in terms of mental health, in terms of anxiety and depression, active surveillance was certainly no worse than radical treatment. So the PROTECT study did add a lot of information and a different perspective. Going back to the specifically to predictors of well-being, some studies showed that negative feelings about oneself and also perception of physician roles, so the extent to which physicians supported the idea of active surveillance, were very significant in terms of predicting well-being in the long term. Our studies showed that, again, the physician's role was very important in predicting well-being over the long term, and also people who had a spouse or significant others were more likely to protect, to maintain their quality of life and their well-being over time. Another aspect that was found to be particularly related to well-being was illness uncertainty. So related to this particular aspect, we can say that it's fundamental to have proper information, comprehensive information, and asking for information is something that always should be kept in mind. One further question that I'm often asked is how often anxiety brings men to drop out from active surveillance protocols. So the numbers in the literature vary a lot from 1-2% up to 12-15%. it's very difficult to conduct research on these topics because different researchers measure different things, and it's a very challenging field of study. The Finnish group recently published a paper showing that only 3.5% of men dropped from the protocol without medical indication. So their dropout was not related to a progression in the disease. In our sample, we found that 1 to 2% of patients decided to leave active surveillance without medical indication. And it's hard to say that they left the program, the protocol, due to anxiety, because at some point we decided to call patients and ask them what was the reason why they had taken that decision. And a number of factors, a number of variables emerged from those conversations. Sometimes it was anxiety. I don't sleep at night because I keep on thinking about my disease. Other times, the decision of dropping out was related to one spouse or some other family member asking for further opinion and finding someone, a physician, saying, no, you're crazy, you should treat your disease, you should, immediately go to radical treatment. And so family conversations about how to deal with prostate cancer oftentimes were the trigger to move to active treatment. What we did found is that overall, men who enter active surveillance protocol experience an increase in their sense of control. And once they understand, once people like that have the same experiences that you've been having, they become more comfortable with the idea of living with untreated prostate cancer. We also saw a decrease in anxious preoccupation, in cancer-related avoidance thoughts and behaviors, and fighting against cancer reactions. So while at the beginning, right after the diagnosis, emotional reactions may be a bit more dramatic, let's say, over time, they go back to a level of control, of comfort. It's more important and more interesting to address another question, not so much how many men drop out, but why men drop out from active surveillance. And the reasons for dropping out are mostly the experience that men have at diagnosis and follow-up consultations. So oftentimes the conversations with physicians, the level of involvement in the shared decision-making, the extent of supportive care and information, and also it has a role, the burden of administrative procedures, and again, support from partners and peers. As I said before, we're still trying to find exactly what we should be looking at when addressing the topic, when addressing research on psychological aspects of active surveillance. right before the pandemic, we published a study that together with the different centers that are, have been promoting active surveillance since the beginning, and we drafted a consensus paper on what to look at, what to compare to, and the paper is specifically has to do with setting an agenda for investigating quality of life and active surveillance. And maybe for some of you who are particularly involved in the advocacy activities, this is a document that you might want to have a look at, and that can be useful in terms of asking what kind of aspects that have not to do with medical variables should be taken into account when active surveillance is offered. One of the things that pretty much in the whole literature has been emphasized is the key the key role of patient engagement and of implementing a shared decision-making process. And that is why multidisciplinary teams are particularly relevant, because the fact that different professional, different people with specific expertise, skills, and perspectives can work together is really an asset for patients, because multidisciplinary teams are more effective in providing disease-specific education. Multidisciplinary teams likely have or should have a professional with a psychosocial background that facilitates conversations between not only the physicians and the patient, but also the physician and the family of the patients. What is extremely important is physicians training in communication and interpersonal skills, because it's not only what men are told about their disease that is important, but also how they are told about their disease. So I know this might sound a bit strange, but probably part of the advocacy activities should have to do with promoting physicians training in soft skills. For a lot of men, active surveillance is an opportunity window, and I'll try to clarify what I mean here. For a lot of men, being diagnosed with prostate cancer is the experience when they first in their life start thinking about their health. So thinking about your health should actually mean thinking about your health overall. A lot of time when I see patients during the multidisciplinary visits, I ask, do you smoke? Do you exercise? And if you smoke, have you been thinking about quitting? The idea is to really start thinking about your health and being proactive about your overall and general health, adopting a healthy lifestyle. So mostly, again, exercise, a healthy diet, and learning stress management techniques. Data is not are not showing right now that there is a direct link between diet specific food and the disease itself, but of course diet and exercise impact significantly on cardiovascular health, metabolic health. So as men on active surveillance, you should take care of your own body and mind. That's the main message. And we don't know yet the direction, the future results that we will have from studies focusing on exercise and diet, but it's a quite interesting line of research, and hopefully we'll understand more. But we do know already that overall it's important for men with prostate cancer, on active surveillance, to be proactive in promoting their general health and well-being. So if we refer to recent literature, and I think of my own experience working in a prostate cancer unit, the interventions that are needed to promote well-being are information and education, receiving coping and psychosocial support, and receiving lifestyle information and counseling, and implementing changes in lifestyle. And I have tried to cover a number of different topics, and now I leave it to the moderators with the questions that emerged.
Well, Lara, thank you so much. Great presentation. Although we try to focus on active surveillance, a number of the men in the audience have more advanced cancers, and we can get into that. I'm going to ask a few questions I plucked out of the list from the audience. And excuse me, it's funny. Let's see. So somebody asked, is there a comedian or comedy video that addresses anxiety around watchful waiting? Well, he refers to watchful waiting, but there is a Scottish comedian who has a number of diseases, and prostate cancer is one. And he talks about going to the bum doctor. I guess that's kind of British there, but any rate, it's Billy Connolly, who's very funny. And I can't say I've pre-screened this, but I'm going to put in the chat title. Second here. Okay. Check out Billy Connolly. And if you want some laughs, I'll give you a laugh that I had this last week. I got together with my two brothers, and one of them just turned 65. And the other one was an audiologist for the Veterans Administration at the Jesse Brown Center in Chicago. And he said they used to put on health fairs, and people would come in for this test and that test for free. That's a whole other debate. But he talked about the number of women who came in and heard there were free prostate exams, and they wanted to know where they got theirs. So think about that. At any rate, Lara, I'd like to ask you a bit about your practice. You mentioned that you're in a special unit, but you didn't talk about the role of the psychologist in a multidisciplinary team in Italy. Now, in breast cancer, multidisciplinary teams are not uncommon in the United States. That brings together like a breast surgeon, medical oncologist, et cetera. But how does it work in Milan for a psychologist? Who is on your team? What role does a psychologist play in interacting with these men who are just considering active surveillance?
This is the way it works. Every Friday, there's the multidisciplinary visit. So the first visit that men have after they receive the diagnosis. So the visit is open to men who already received the diagnosis of prostate cancer. And we sit together, urologist, radiation oncologist, and the psychologist. And usually the visit starts with the clinical information, collecting the clinical information from the patient, and it's interesting because at the beginning it was more, after that part, the clinician started to explain. Now, after 10 years of sitting next to a psychologist and an expert in patient-physician communication, they start with a question. What have you understood about your situation? What have you understood about your disease? Because we give some time to the person to express how he's dealing with diagnosis, and if there are specific aspects that need to be clarified in terms of information, and so we take it from there. And the whole visit, it's the three of us. At some point, we had more resources, and we were two psychologists rotating during the morning. So the psychologist that was sitting during the visit with the physician then will go out and have a further like 20 minutes of counseling with the patient, and then the other psychologist came in. So we were rotating. We don't have the opportunity to do that any longer, but nonetheless, we are now, as a psychologist, working in situations in which if we notice that the persons are not paying attention because they're anxious or because there's an overload of information, we stop the physicians, we ask questions, we say something, we ask questions that allow patients and their family to ask questions then the physicians will address. So there's an interplay among the three of us that is quite important. And I'm telling you, it hasn't been like that since the beginning. I remember that in 2009, when I first started working with the clinicians in the multidisciplinary visit, oftentimes the visit was interrupted once the clinician had finished to play their part, to play their role, to provide the patients with the information that they needed to provide. But now it's very different, and this way of working is is very well received by men and their spouses, because we as a psychologists are trained to see things from a different perspective, to notice some details that we facilitate to emerge, and that those details over time are paramount to initiate a shared decision-making process. And of course, we offer men and their spouses also the possibility of psychological support. Usually we offer up to 8 counseling sessions, but sometimes it can be less and other times it can be more. Usually we initially offer 8 to those men who are particularly experiencing a particular psychological distress. The multidisciplinary visit is not merely for men who can enter active surveillance. We see all the patients that access the Instituto.
If we could stay with this for a second, Howard, this may be the most important part of the program in terms of that first visit. So I'd like to expand on this and stay here with this issue a bit, because we don't do it well here in America. When I was diagnosed 17 years ago, the doctor spent 15 minutes with me, told me I had cancer, and then I went home. And I would have loved to have gone to a nurse. I would have loved to have heard this multidisciplinary approach. And it's important for us, all of us here on this call, to gather as much information about this multidisciplinary approach, because I think we need it here. And I think part of what ASPI wants to do is improve things for men choosing active surveillance. And so, this harkens back to our webinar about 6 months ago with Ulla Bratt from Sweden. And with what he says, if you have low risk or intermediate risk prostate cancer, he says you have no cancer that needs to be treated. Mm-hmm. No cancer that needs to be treated. And can you imagine the difference in one's consciousness if he hears those words? Then you have cancer, and then you're starting to think, okay, I got to get a radical prostatectomy, now I got to get radiation. It's a whole different thing. And we as a nation, and each nation here may have different approaches, obviously. So for the moment, I'm just speaking on behalf of the US, but we have a long way to come to reach what you describe.
Well, Mark, in the United States, at least, the multidisciplinary approach without a psychologist is rare. And I think the research shows that men benefit from multidisciplinary approach because it isn't the surgeon alone sitting there touting surgery. The surgeon, he or she, has to keep in mind that a radiation oncologist is in the room. And so they sort of temper what they say. But I'd like to bring up another aspect of this. And we've had I should mention that we have a delegation from the Prostate Forum of Orange County. We have people from the nationwide surveillance group, active surveillance group in Canada. We have representatives from Answer Cancer and CAN. And so, they're all about support. And I'm wondering, Lara, in your experience, what can you say about benefits of support groups for men on active surveillance, or lack of benefits?
We have experience in support groups for men who were treated. This is one of the projects that I wanted to implement, and then the pandemic came. I wanted to create a group for men on active surveillance and use that group for both educational purposes on anxiety, well-being, lifestyle, and to offer the occasion for peer-to-peer conversations. So I don't have yet that kind of experience, and this is something that I wanted to look at and implement.
Well, you know, I can volunteer that I hope I can speak for Phil Siegel and groups up in Canada, and certainly the ANCAN group in the United States. And I believe the Prostate Forum in Orange County devotes a lot of time to newbies and people on active surveillance. And I'm sure I think all of us would be available to help you in your research. With the research we've done with ANCAN shows that men definitely benefit from getting support from peers. At any rate, not to dwell on that too much. You know, what about, you know, you have your experience in Italy, and we've spoken before, and I think there was a reluctance in Italy that Italian men could go through active surveillance, you know, in contrast to the men from Northern Europe. And I wonder how much there are regional effects. I've talked to Dr. Klotz in Canada. He seems to think that Americans, you know, tend to have more of an anxiety problem. And a lot of it, he feels, is due to anxiety triggered by doctors who may have something to sell, like surgery. But at any rate, can you comment on that?
I will. I'm just going to say something quick related to what Mark was saying before. In Italy as well, it's not so common to have such a consistently structured multidisciplinary group. It is not. When we started, we were basically the only cancer center with that kind of approach. And the director of the prostate cancer program at Istituto, who's a radiation oncologist, Riccardo Valdagni, has been really supporting the importance of having a multidisciplinary group. So, and then I know now that a few other hospitals in Milano have a similar structure to the one that I was telling you before. In terms of cultural, regional differences, we have been working on a study comparing our sample, the Italian PRIAS protocol, with Erasmus MC. So we're talking about the Netherlands, the group that is led by Chris Bankma and Monique Robol. So we looked at data from our samples and we compared them, and we didn't see differences in psychological well-being, in quality of life. Actually, it seems like in terms of coping, the Italian sample is doing a bit better. And then again, we argue that it has to do with a multidisciplinary approach. But we cannot really make a direct comparison because of course they're using a different model, and it's hard to monitor how the multidisciplinary approach affects the psychological well-being. It's very, very complex, very complex. So we have a bit of understanding of what's going on from qualitative studies. So interviewing patients is a good thing to do. And of course, you lack in numbers because you cannot have very large samples when you do qualitative research. But with that kind of approach, you understand more what's going on. So if research has to be done to understand a bit better why it happens, what it happens, I would suggest to perform qualitative studies, to conduct qualitative studies.
Lara,
Also in terms of cultural differences.
Lara, do you have a question from Alan? He asked, do you have any thoughts about the value of in-person counseling versus counseling via Zoom? And he asks that anyone on this call who has had a good experience with Zoom to enter comments in the chat box. So Lara, what about in-person versus Zoom counseling?
I've been doing Zoom sessions, online sessions, very much, of course. Above all in 2020, last year too. So it's a great opportunity. It's a great opportunity. You don't have to travel or commute to go to the cancer center. It's very convenient, and you can do a lot of work, counseling work online. Totally. So research is showing that the outcomes are good. There are some conversations that nonetheless need a dedicated space and time. So not being in your own home, but being somewhere else, somewhere there is a neutral space for some conversations might be more effective. But again, Zoom online sessions, counseling sessions are definitely feasible and a great opportunity. So I was talking to a colleague at the hospital right before connecting to you, and she was asking me, it was a different topic, which she was asking me for a family member of hers who's suffering from panic attacks. And he lives in a place where it's not very convenient to reach a therapist. And I suggested to try to find an hybrid solution. So do most of the counseling online, but at the same time have the opportunity to go and see the therapist in the office once in a while.
Howard, could I interject one of the questions here in the chat
Sure.
box? Because I think it's a really important one, and that has to do with the question from Randy Apsel. And he asked, does it help to reduce anxiety to have a plan for when we drop out of AS? And I want to try to begin to respond to that and then turn it over to Lara. I think that knowing that we can successfully progress from AS to therapy, to medical intervention is reassuring. And I would imagine, and we've dealt with that a little bit here in this program, by the way. We have two board members, and we had a program where they spoke, Throne and Joe, who have both progressed from active surveillance to treatment. And they've done it gracefully and successfully. And so that's important for all of you to know, that you can progress from active surveillance to treatment. Things have progressed so much in the past 17 years since I was diagnosed. Thank God I didn't have to progress to treatment 17 years ago. So just that knowledge should help to reduce your anxiety. But it may be worthwhile for you to dig into that a little further yourself, and we probably will in one of these sessions too in the future, to give you some different ideas about how that works, so you'll be more reassured that it can be done successfully. Lara, do you want to add anything to that question or not?
Just very briefly, and then there's a question that I saw that I'd like to address. It might be useful to co-create plans with the physicians that you're working with. And I'm using these words with intention, working with. So if that is something you need to have, like a sort of a plan, which, and you know, protocols may be different in different countries and in different institutions. Like in Italy, at where I work, men have a really set program, so they really know when they're gonna have to move to active treatment. So it's not okay. We monitor what happens, and you know, we see time after time. So I find it hard to like really address this kind of question, because it can, you know, the protocols can change. The management of active surveillance can be very different from place to place. But overall, what I'm saying is it's good to have a program, a plan, and that plan has to be co-shared, co-created with the physicians that you have decided that you want to refer to.
Yeah. Lara, there's a question here from Brian that kind of...
Can I just address something that that comes from Richard? Because he says, if a person is anxious by nature, that person will be anxious whether he chooses active surveillance or if he chooses treatment, meaning the patient will not avoid the anxious part of active surveillance if he chooses treatment. Yes, yes, and yes. It's a really good point, and thank you for addressing it, for bringing it up. Oftentimes I joke, and by saying this, I also address someone who mentioned the usefulness of humor, of developing humor in dealing with disease and challenges. I oftentimes make this joke. Prostatectomy is not the treatment, the cure for anxiety. Meaning that it's understanding one's fear, one's anxiety is what you need to do if anxiety is particularly relevant and intrusive in your life. And after that, if you have the medical condition that is appropriate, you decide whether you want to go for active surveillance or radical treatment.
I was going to throw in a comment and question from Brian that sort of flips the argument or discussion. You know, we're talking about the cancer leading to anxious surveillance, but he raises the question, is it also possible that being on active surveillance could bring on feelings of relief, with the understanding that the situation could be much worse, with higher Gleason scores, metastases, serious symptoms, etc. Being eligible for active surveillance may be the best of all possible situations to be in. So what do you think, Lara?
Well, and that's a huge part of the understanding process, of the process of understanding that prostate cancer, that there is no one prostate cancer, that the word cancer doesn't necessarily imply death, that the diagnosis you're receiving is not so, is not a threat to survival. So of course it's reassuring to know that you're eligible for active surveillance. Of course it is. And I'm playing a devil's advocate here. Make sure that you don't take that information as I have no cancer, because oftentimes, you know, that can lead to disappointment, frustration in those cases when that in which men will have to switch to active treatment. Understanding active surveillance, understanding the opportunity, the possibility of active surveillance is very complex, cognitively and emotionally, because you're being told you have cancer, and that, of course, emotionally, you know, has a strong impact. But at the same time, you're being told, you're being reassured, in a sense, that your cancer is not a threat to your survival. So both cognitively and emotionally, the process is complex, and it takes some time. It takes some time, and it takes good conversations with your doctors, and it can benefit to see a psychologist to facilitate the process of understanding.
By the way, it's getting to be 1:30. I wanted to ask you, Lara, if you would be willing to stick around for a few more minutes or not.
A few more minutes, yes. Then I will have to go because it's 7:30 p.m. here.
Okay, 10 minutes, is that reasonable?
5?
Okay,
No.
we can negotiate. By the way, your program has been outstanding. And actually, for those of you that are in the program, now there's a whole bunch of good comments in the chat box that I'm reading right now, and I'd encourage you to take a close look at them. And one of the ones that was early on had to do with humor, and he belonged to an I forget the fellow's name. I think it might have been Alan Amory or something. An association for the therapeutic. There's actually an association for therapeutic humor, and we've heard that humor is the best. Laughter is the best medicine. In fact, you know, I wonder if there's ever been any study on laughter and healing, laughter and anxiety. Any research on that issue or not?
There's a whole movement. There's even a movement that is called yoga laughter. At this point of my professional life, I am particularly interested in implementing theories and tools that come from positive psychology. So talking about humor, talking about one's resources, talking about post-traumatic growth, talking about gratitude is something that I'm doing a lot with the men that have counseling sessions with me, both in my private practice and at the hospital. I think it's active surveillance really offers that learning window to kind of, shift your perspective about yourself, to understand more how you want to live your life, what are you grateful for, what can you laugh about. So definitely looking at those resources such as humor, gratitude, compassion towards yourself when you feel that despite you've been reassured that your disease is not a threat, you feel down or you feel anxious. So looking at those kind of things is definitely a good way of staying in active surveillance.
Well, and I just want to share with you, you mentioned gratitude. I have a number of grandchildren, and we have a 4-year-old grandchild. And whenever we sit down and eat with him, he insists that we hold hands and share the gratitudes for the day. So whether it cures cancer or just gratitudes are a great gift. And sharing gratitudes are a great gift, and whether it works for cancer or not is irrelevant. It's a great gift to.
Yeah, I'll leave you with this tip. Try for a couple of weeks this practice. Every evening, write down 3 things for which you are grateful, and they have to be specific. Very specific. Do it for 2-3 weeks, then stop, and then you can, start again after a couple of months. And this practice, some studies report that it improves well-being, mood, and it lowers the stress hormones. So I'll leave you with this tip, and hopefully it will be useful. I want to thank you for this opportunity, and I want to thank you for all the wonderful questions and inputs that I see on the chat. And really, it's been thank you for your attention and for this time together.
Well, we are very grateful for you, Lara. Thank you so much.